Hi everyone. In this chapter, we are going to be talking about case planning and intraoperative routines. And a lot of this should be familiar to us. I'll go into a little bit more detail. And of course, as we continue to practice our skills in the labs, this is going to come full circle for us. So the book talks about several different types of surgical techniques. There's a lot of terminology that goes along with that. Make sure you also review the terminology in the very beginning of the chapter on page 400 as well. So I'm just going to quickly go through each of these terms. Amputate versus removal. So if we're amputating something, that typically refers to a leg, an arm, a finger, a toe. When we're removing something, that typically refers to other body parts like organs and so on and so forth. You would amputate a toe, but you would remove the spleen, let's say. The difference between anastomose and anastomosis. So remember, an anastomosis, or to anastomose something. Anastomose is a verb. Anastomosis is the noun form. But this occurs when we have some sort of tubular structure, like the intestine is a good example. We've removed a part from it, and now we got to hook that tube back together. All right, so the process of hooking it back together is called anastomose. I'm going to anastomose the small intestine, but the noun form is anastomosis. So I performed an anastomosis on the small bowel. The term approximate, you will hear this in conjunction with in different situations. One that jumps out at me is when we are closing the wound with skin staples. So the surgeon will take 2 Adson forceps with teeth and will grab each side of the wound, the skin edges, and bring them close to each other. This is called approximating the skin. And then you, as a surg tech, are going to place the staple. Blunt dissection is the opposite of sharp dissection. So sharp dissection, we're going to use a scalpel, cautery, maybe scissors, something of that sort. But blunt dissection is more kind of teasing tissues apart without cutting them apart. This can be done with a Kittner sponge, which is just a little round peanut-shaped sponge that's attached to the end of a clamp. It could be done with a sponge on a stick. I've also seen surgeons take a lap or a Raytech and kind of put it around their finger and use their finger to tease tissue planes apart. The chief of surgery I used to work with called that a finger fracture. Let's see, moving on to debridement. So a debridement is when we have some sort of infection or burn or dead tissue, devitalized tissue, and they're wanting to clear that tissue away. So they're going to remove it via a debridement, scraping away or cutting away of that devitalized tissue. This can also happen in traumatic wounds if we have like road rash or something of that sort. Now, a dog ear, if any of you are sewers out there, you have probably come across this situation where you're sewing 2 pieces of material together and you get to the end and there's like a little extra fabric. The same thing happens can happen when we're sewing a wound. And so that's why a lot of times you'll see the surgeon, before they even make the incision, draw a line where they're going to make the incision and then draw little hashes across the line. This is going to help them to be able to line up that skin incision when they get ready to close it, so they don't end up with like a skitty-wampus closure where they have this little lump of tissue on the end because things weren't straightened out properly as they were closing the wound. Debulking. Debulking can refer to removing a tumor, a cancerous tumor, where they remove some of it or most of it, but not all of it. Okay, dissecting. We've heard this term. We've all probably used this term, but it basically means to separate anatomical structures with instruments or a sponge or something like that. Again, tissues have planes, and so the surgeons are going to want to create as least amount of trauma as possible, and as they're dissecting, they're going to work along those tissue plates. When we're elevating something, to elevate means to lift, right? We've all been in an elevator that took us up to another floor in a tall building or a not so tall building, as it were. There are instruments that we use in surgery called elevators. They have kind of a sharp dissecting edge. A good example would be the bone has that thin covering. Remember, back to anatomy, the periosteum that covers the outside of bones. We can use an elevator to remove or lift that periosteum, all right? And that would be an example of elevating a tissue. Excising something simply means to take it out, okay? To expose. To expose means to create an opportunity so that we can see a specific area in surgery, right? The surgeon wants to expose the gallbladder. If we don't expose the gallbladder, we can't see it to remove it, right? So to expose the gallbladder, we would lift and raise the liver or find the bulbous a portion of the gallbladder and grasp onto that and lift it up so that we can expose those structures that we need to dissect and ligate that are below. To exteriorize something simply means to bring it to the outside. A good example of this is if we are doing a bowel resection, one of the things that surgeons commonly do is mobilize the bowel. And by mobilizing the bowel, that means freeing it up so that they can bring it up and out of the wound so that they can work on it a little more easily. To ligate something simply means to tie it off, to separate it. If we're talking about a vessel, then the process is usually to clamp it in two places, to cut in between those two clamps, and then to tie it. So we use the mantra in surgery, clamp, clamp, cut, tie, which would be the tie part would be the ligating part, right? A vessel has two ends, so if we cut it apart, we're going to get bleeding from both sides, and so we want to control bleeding on both of those ends. Couple more to go. A resection. A resection is where we remove a large portion or segment of tissue, hence bowel resection or colon resection. And then could potentially be followed by an anastomosis, right? To undermine tissue is to dig underneath. When you guys were kids, or maybe even now, have you ever dug tunnels in the sand or the dirt? When you do this, you're undermining, right, that top layer of dirt. Sometimes it does fall in, other times it doesn't, and you're able to create a really cool tunnel in the sand. A similar thing a surgeon can do in surgery when they undermine a tissue. One example of this is to undermine the skin so that it can be lifted up off from the fascia. I have seen this personally when sometimes when we're doing breast biopsies and they take a fair amount of tissue from the breast, and now they have to kind of undermine the skin away from that adipose tissue to help it kind of fill in that void before they go ahead and sew it up. Because if they don't do that, they're going to leave this cavity in the breast, and that is just an opportunity for a seroma to form, and we don't want that. So anyways, an example of undermining. And then lastly, visualizing. To expose is a lot similar, right? To expose something is to make it so that we can visualize it. Visualization or direct visualization is what a surgeon is going to need to be able to operate on something, and sometimes that becomes our responsibility either by holding a retractor or by holding a camera that's attached to a scope when we're doing laparoscopy or arthroscopy or something like that. So we would be the surgeon's eyes at that point. So we're going to talk about some tasks and duties of the different players in the operating room. And if you check out the table on page 402, it's going to give you a very detailed list of what the scrub, the circulator, the surgeon does before, during, and after surgery. Okay, so I think you're getting a good sense of what we do before, during, and after surgery. Before surgery, we're going to gather all of our things, open them up, scrub, gown, glove, jump in, set up, count, get our meds, get organized, set up our Mayo stand, gown and glove the surgeon, help the surgeon with the draping, and then that intraoperative part starts after the timeout when we make the incision or we inject the patient with local anesthetic. That's kind of the dividing line between pre-op and intra-op. And in that preoperative time, the circulating nurse is helping us. Okay, we're kind of working together as a team to get ready for that surgery. And the surgeon, who knows what they're doing, right? They could be talking to the patient in pre-op, or they could be sitting in the lounge and having some coffee. They could be making rounds before they do their first case. They could be at the office and we're waiting for them to come over. There's a variety of things that surgeons will do, but they could come into the operating room and help with put the tourniquet on, if that's the case, shave the patient, help position the patient, those kinds of things. So they can be a help to the circulator during that preoperative phase as well. Intraoperatively, we're going to be doing the surgery, right? We're going to be anticipating the needs of the surgeon. We're going to be performing additional counts, retracting, sponging, suctioning, passing instruments, passing equipment, passing implants, handling specimens, all of those fun things. And the surgeon's going to be doing what they do depending on whatever the surgery is. And the circulating nurse is going to be standing by in case any of us need anything. All right, if we need more sponges, boom, they got them. If anesthesia needs more fluids for the patient, boom, she goes and gets them. So the circulating nurse is also going to be filling out some paperwork intraoperatively to document what's going on during surgery. At the end of surgery, and you guys can read through this and look at all of these details. So I'm just going to give a kind of a sloppy recap here. So at the end of surgery, surgery ends when you put the dressings on the wound, okay? Then you transition from intra-op to post-op period. In the post-op period, surgeon's gonna hit the door and probably go dictate the surgery that he just performed. He has to call a special number, or she get on the phone and say, I just did a laparoscopic cholecystectomy on so-and-so and so-and-so, and this is all the things that transpired, step by step by step. All right, you might also peek into the recovery room to see the patient post-operatively. On the other hand, we're going to be cleaning up. We are going to break down all of our instruments, and we're going to get them to decontam. Prior to that, if they need help transferring the patient back to the gurney, we could help with that too. Take the instruments to decon and then come back and help turn over our room, right? Which requires maybe grabbing a mop or a rag, making a bed, bagging some trash, all of those fun things, all right? We're gonna get rid of our sharps in the right way. We'll talk about that a little bit more. The circulating nurse, they'll typically help the anesthesia care provider get the patient to the PACU, and then they're gonna help you turn over. They're also gonna go see the next patient. And then the thing kind of starts all over again, right? So as a group, you can kind of dig into these a little bit more and kind of look at some of the things that I might have skipped over. Case planning. There's a lot that goes on for case planning, and there is a difference between case planning and case management. Case management is referring to a team perspective for patient care, right? It's involving multiple disciplines, looking at the patient from a very holistic approach, okay? Case planning refers to the preparation for a surgical case. And so that's what we're going to talk about, is the case planning part. All right, so the first thing that we need to think about is, what surgery are we doing, right? What is the name of the procedure and what type of procedure is it? Meaning the name of the procedure could be laparoscopic cholecystectomy. The type of procedure could be emergent, or it could be elective. All right, is it need to get done in a hurry? Is there an emergent situation going on with the patient, or can we take our time, so to speak? Okay, so the type of procedure. We also want to think about the diagnosis, right? The diagnosis is important. That's going to be stated in the record. We might want to know why the patient's having this surgery. We'll use the laparoscopic cholecystectomy as we kind of go through this. The preoperative diagnosis could be gallstones, all right? Gallstones is called cholelithiasis. We also want to think about, are we going to need to get the lab involved? So are we going to need to do a frozen section? Are they going to need to take a look at the specimen intraoperatively so that we can get some feedback and do what we need to do for the patient? Okay, or is it just going to go afterwards? If that's the case, we really don't need to tell them anything about it or get them involved. The specimen will just go to them and they'll care for it as they usually do. Patient information, right? How old are they? Can they move on their own? What type of sensory deficits do they have? What position are we going to need to put the patient in so that the surgeon can expose the site that he or she needs so that he can perform the procedure? Okay, what type of prep? Okay, we have to think about patient allergies when we are determining what type of prep. The surgeon's preference card is going to tell us that, right? So that's where we're going to go to look for the type of prep and the drapes and the instruments and the equipment and the implants and all of the surgical supplies. The preference card is going to tell us that. But for the prep and for the medications, we need to inquire about the patient allergies, right? And then we need to think about how we're going to drape the patient. Sometimes it's not straightforward, all right? And the preference card isn't going to tell us. We have to do a little bit of critical thinking, and we might have to ask some questions. For example, if we have a patient that had a burn on their back and we're taking a skin graft. Okay, first of all, we need to know where we're going to take that skin graft from. Has the patient already had 4 skin grafts from their back of their thighs? Then we're not going to be able to take a skin graft from there, and we're going to have to start with the patient in supine and take the skin graft from the front of the patient, and then they're going to have to be repositioned. So those are some questions that we need to ask, and those are some things that we need to think forward about, because it's not always cut and dry as far as the draping goes. All right, the various sutures, drains, and dressings, those things should be on the preference card. Okay, but that doesn't mean that you just look at the preference card like a robot. Okay, you're not a brainless thing, machine that's doing this procedure. So always think if there's anything that might make sense that the preference card isn't saying. Okay, and sometimes things don't get added to the preference card. Sometimes you work with Dr. Bob, and Dr. Bob likes the special drape, but the special drape has never gotten put on the preference card. I don't know what the situation might be. I'm just saying, don't be a machine. Okay, be a critical thinking individual. And then lastly, an important component of the case planning is the patient destination. Are they going to bypass the PACU and go straight to ICU? Are they going to go to the PACU and then be discharged to home? Are they going to go to PACU and then go to the surgical floor or the telemetry floor or something like that? Okay, and that is case planning in a big nutshell. So another component of surgical case planning is the type of surgery. And there are 4 basic types that the text covers: diagnostic, reconstruction or implant, repair, and removal. All right, so diagnostic is usually a procedure that's performed to give us a better understanding of what's going on with the patient. A lot of times those are minimally invasive procedures like colonoscopies, diagnostic laparoscopies, hysteroscopies, arthroscopies, any of the oscopies, for the most part, can be diagnostic if they're in the operating room. Also imaging, different imaging procedures can also be diagnostic as well, and we may use them intraoperatively in conjunction with those oscopies that we've already talked about. Some questions that we might want to consider is, what is the structure that the surgeon is interested in, and what type of technique will be used to perform the diagnosis? Are they going to do an intraoperative biopsy that needs a frozen section before we can do what we need to do? Are they going to inject some sort of dye? Are they going to inject in some radioactive isotope? Are there going to be special equipment that's going to need to be used? And how is that going to be documented? Do we need to let X-ray know that they need to be in our OR for this diagnostic study? Are there previous imaging studies that have been done that we need to have in the operating room, or the surgeon needs the ability to pull up on a computer or something like that? And then what type of anesthesia is going to be required as well? So those are some things that they'll think about and that we can think about as far as questions that we can ask to help us plan. Okay, reconstruction or implant surgery. If we are doing this type of procedure, it could be a breast augmentation. It could be we're doing a total joint reconstruction. There are a variety of different implants that we could put into our patient, and it's super important before we start the procedure that we do our checks and balances and make sure that we have not only the right instrumentation and or equipment, but the correct implants are there as well. If we're doing some sort of repair, all right, the goal of a repair is to restore function, and that could be a myriad of things. Okay, we could be repairing a tendon, we could be replacing a heart valve, and anything in between. Okay, so some questions that we can think about is, what are we repairing and what instruments are going to be needed? Are there going to be certain materials that are needed? Let's say we are doing a bypass graft on an aorta. Are we going to use some sort of PTFE graft or Dacron graft? So making sure that we know what type of material is going to be used to do the repair, if indeed there is some sort of material going to be used to do the repair. And how will it be held in place? Do we need special sutures? Are we going to need screws or plates or some sort of glue or cement? Okay. Will we need x-ray or some sort of fluoroscopy in the operating room? And, you know, is there a possibility of excessive blood loss associated with that? And then lastly, removal. Removal is taking out any type of organ or tissue, or perhaps it's a foreign body. These we usually refer to as the ectomies. All right, tonsillectomy, splenectomy, hemorrhoidectomy, any of the ectomies. That means we're going in and cutting something out. Okay. Some questions that we might want to think of is, what's being removed and what approach is being used for that? Something that jumps to mind when I read that in the textbook is a prostatectomy. There are several ways that we can remove the prostate. We can do it with the Da Vinci. We can do it open, where we make a traditional incision, but there's suprapubic prostatectomy. There's also other different approaches to remove the prostate. There's a transurethral resection of the prostate. So we want to make sure that we know what approach the surgeon is using so that we can position the patient properly, we can make sure we have the equipment that we need and the instrumentation that we need. Okay. Excuse me. So those are the different types of surgeries and the questions that we might think about and ask depending on what type of surgery that is. All right, so now we're going to move on and talk a little bit more about preoperative case prep in a variety of different areas in a little more detailed fashion. So first on the list is opening a surgical case. Okay, you guys have all done this. So think about the things that you did. Now, something that we haven't done is, if it is the first procedure of the day, we are going to damp dust the entire operating room. We're going to start in the middle with the OR lights. We're going to wipe down the OR lights, wipe down the OR table, and then work outward to any other flat surfaces, back table, Mayo stand, Bovie, anesthesia machine. All the flat surfaces are going to be damp dusted before we check our supplies and spread our supplies and then actually begin opening our supplies. All right, we're going to open the supplies using proper technique. We've been practicing those in the lab, and once we get all of our stuff opened, that is when we will go scrub in. Okay, where are we going to find all the sterile supplies that we need? Those are going to be found on the preference card. Okay, before we open, we just want to make sure that we position all the equipment where it needs to be, check the integrity of all of our packages. We're looking for rips, tears, holes, strike through. We want to check the chemical indicator as well as the expiration date. Okay. When we open our case, we want to make sure that we maintain that distance when we're opening 12 to 18 inches and that we apply all of our principles and practices of aseptic technique. Once we are scrubbed in and we have completed our count and received our medications, this is typically the time where the nurse will go get the patient, all right? And that is called receiving the patient. So while we are setting up our field, the patient is going to be brought into the room, typically by the circulating nurse and the anesthesia care provider, right? If you want at this moment, you can stop and greet your patient. Hi, my name is Rhiannon. I'm going to be your scrub tech for today. We'll take really good care of you. Okay? You can stop and do that. If you don't want to, that's okay too. They are not going to remember you one little iota. So it's okay. You can remain anonymous behind your mask at your back table. Okay? So once the patient gets in, then they're going to move over onto the operating room table like we have practiced in the classroom. And once they get over there, then you're going to get the arm boards, they're going to get the little safety strap, and the anesthesia care provider is going to go ahead and administer the anesthesia. Once anesthesia has been administered, then the patient is going to be positioned, okay? And then once the patient is positioned, that is when the nurse will prep the patient. And typically, if there aren't any other fun festivities for the surgeon to help out with, they'll usually come into the room around the time the circulating nurse is doing the prep. And then that's when we go ahead and give them their towel, their gown, their gloves, and we're going to get ready to drape the patient. We will help the surgeon with the draping of the patient if there isn't an assistant in there. If so, we're just going to kind of be passing the drapes in the order that they need them. And once we get the patient draped, we will all move into position, okay? And then that's when we're going to perform our timeout. All right, once the timeout has been performed, then that is when we're going to go ahead and pass the scalpel or pass the marking pin, pass the local anesthetic, whatever the surgeon needs to get started with, all right? It's important when we do the timeout that we stop everything that we're doing, okay? We want to stop everything that we're doing and pay attention, okay, to the timeout, okay? When we're setting up our field, we want to make sure that we are anticipating the needs of the team before we even start the surgery, right? We want to think about what sutures we're going to need first. We want to think about what instruments we're going to put up on the Mayo stand, how we need to prepare the medications. Do they need to go into a syringe? Are they going to be loaded into an asepto? Those kinds of things. We want to be taking this time to get in the game, all right? And get our head in the right place. Think about the steps 1, 2, 3, 4 that we can anticipate, all right, for the surgical procedure. Okay, so let's talk a little bit about the counts, okay? It is our responsibility to perform the count, okay? It is not the surgeon's or the circulating nurse's job to say, hey, it's time to count. It's our responsibility, okay? And so let's talk a little bit about when. All right, so when do we perform counts? Well, we already know that we perform a count preoperatively before surgery begins to establish a baseline count. Intraoperatively, any time any sponges or countable goods are added to the field, we need to stop and count those. So let's say intraoperatively we're working away and the surgeon's burning through Raytex sponges like they're going out of style, and we get another package of Raytex on our field. At that point, we need to stop and we need to count with the circulating nurse those new Raytex that were added to the field. Okay, so anytime a countable comes to the field, we need to count it. Now, before we close any cavity or cavity within a cavity, all right, we would need to count. An example is the C-section. Okay, let's say we're in the C-section and they get ready to close the uterus. The uterus is a hollow organ. We would need to initiate a count. If we did not go into a hollow organ, then the next time we would count would be at the start of the wound closure. So when you pass that first closing stitch, you will initiate your closing count, and then your final count will be at the close of skin. Now, some exceptions to this would be if the scrub there changes intraoperatively. So let's say it's your lunchtime and somebody comes in to relieve you, then you're going to do a count. Okay, that other person's going to be there watching that's coming in to relieve you. You're going to do your count and be gone. Okay, when you come back, you have to do the same thing. You're going to have to do another count. It's intrusive. It's interruptive. Is that a word? I don't even know. Disruptive. Yeah, okay. So, and then if the circulating nurse changes, then they would want to do a count as well, okay? So what is the procedure for the count? Intraoperatively, we're going to begin the count on the field. We're going to look to see if there's any sponges on the field. Remember, we've been having you put 2 Raytex up on the field, so you would start there. Raytex, 1, 2 on the field. Then you're going to go to the Mayo stand. The next place you would look for Raytex, if you hadn't found them all yet, is the back table, and then the last place would be off the field. Now, you're not going to count the ones off the field. The circulating nurse is. If there is any in the kick bucket, that's where off the field typically is. The nurse is going to count those, and you are there to verify. Okay? Let's see. Some fancy facilities have counting systems where the items are barcoded, or they have radio frequency little devices sewn in to the sponges and those kinds of things. So there are some counting systems out there that are being used for checks and balances as well. Now, in the case of an emergency, we are going to forego a count and more than likely do an x-ray at the end just to make sure we didn't leave anything in. Because if it's a life and death emergency, we're just going to focus on saving the patient. Okay, we're not going to take time to count our things. Again, an x-ray would be performed afterwards. All right, all counts are documented on the operative record. Sometimes if there is an incorrect count and we just can't find that thing, then we're going to have to do an x-ray as well. Okay, and that is considered, if we do leave something in, that is considered a sentinel event. Okay, when you hear sentinel event, think lawsuit. Okay, moving on to lost or retained items. Lost or retained items. Either we can't find it, we left it in. So how do we lose items? How are they lost? Well, it could be that the procedure was very long and there were multiple changes throughout the procedure. Items can get lost that way, right? Multiple scrubs coming in, multiple nurses coming in and out, high turnover, all right? If a sponge is used inappropriately, like the book gives an example, when we are doing a belly case or a chest case, and typically we don't want to give them Ratex unless they're loaded on a sponge stick, but let's say one got loose, okay? That is a way that it can, that Ratex can get lost in there. Also, somebody documented something incorrectly. Maybe the nurse wrote something down incorrectly. The sponge count wasn't performed properly. It could be that there is, really loud old school rap playing in the background and you just can't hear very well, okay? Don't be afraid to say, hey, can we turn that down for a minute while we do our count? All right, so how do we search for a lost item? If we do a count of the Ratex, let's say, and we only come up with 9. Remember, there's supposed to be 10. So let's say we count 9. And the first thing that you want to do is just assume that it was your own counting mistake and count again. Okay, if you count a second time and you're still coming up with 9, then you want to start looking around. You want to start looking around on the floor, in and around the OR table. Perhaps it is under your Mayo stand. Sometimes where the Mayo stand goes over the patient, that's a good place for things to get misplaced. So you want to start looking around, under shoes, between feet. The circulating nurse is going to help out. They're going to maybe check the kick bucket, or if they have put the sponges in the little counter bags, maybe they put 2 in one bag accidentally. They're going to go through those things. Worst case scenario, they might start digging through the trash. Okay, so how do we prevent things from happening like this? All right, one way is to limit your talking and focus on your procedure. During the count, eliminate unnecessary activity and distractions, right? Follow facility policy. Make sure the facility has a standardized procedure. Keep all of your little sharps together like they're little ducklings. They want to be together. When you're not otherwise engaged in the procedure, do a quick count intraoperatively, just to, a mental check of things. All right, stay organized. The more organized you are, the better. Okay. If you noticed in the lab, there's a little band around the Ratex. Now that is not the original band, but every package of sponges comes with a little band. A good procedure to follow is don't break that band until you are ready to count those sponges, okay? And don't ever take any counted items outside of the operating room, okay? If there are counted items that are on the floor, that should be communicated to the circulating nurse, and the circulating nurse should get those right away. Okay, small components should be counted separately, like the little wing nut on the Balfour. Okay, and you don't, if you have a really trashy case or a case where there's a lot of linen, you don't want to take those bags out and put them in the big dumpster. You want to keep all the trash from that case in that room. You can tie them up and put a new bag, that's fine. Just leave those in the operating room. Okay, and so those are some ways to how items are lost, and then how to reduce the chance of items getting lost intraoperatively. So again, starting the case. After the timeout, we want to make sure that we keep our field as organized as possible. Keep the Mayo stand as orderly and tidy as possible, the field at the patient, the back table, everything. Correctly manage your sponges and sharps. We want to make sure that if we are working in the abdomen, that we are using moistened sponges to protect the organs from those retractor blades. The circulating nurse is also going to turn on the lights for us and adjust the lights. We want to make sure that we have adequate lighting in there, right? And then instrument passing. We just want to make sure that we are handling the instruments appropriately, we are passing them safely, and that we are always trying to anticipate the needs of the surgeon. When we are in surgery, the only way that we can anticipate the needs of the surgeon is to look at the operative site. There is no other way that you can anticipate what the surgeon needs unless you have your eyes on the field. So my advice to you is to talk as little as possible and to listen twice as much, right? We have 2 ears and 1 mouth for a reason. We should listen twice as much as we talk, especially when we're new. Focus on the field. I have had clinical sites call me about students saying, we really like this student, but they talk too much. They are not paying attention to what is going on the field. Keep your mouth shut, keep your ears open, watch the field. I swear, it is a winning trifecta, okay? Also, knowing the instruments, knowing the procedure, understanding anatomy and physiology, all of those things definitely help as well. And then we're using some hand signals in the lab, so hopefully you'll be familiar with those when you go out there as well. But recognizing hand signals, that's also a thing. Handling specimens. So as the surgical tech, you will be handling specimens and you may be labeling them or communicating to the circulating nurse what the surgeon wants the specimen to be labeled. Okay, so for me, as the surgeon, I always want you to ask me 3 questions about the specimen. The first one is, what is it? Okay, what is it? How would you like it sent? Okay, does the surgeon want it dry in a specimen cup? Do they want it in formalin, which is permanent? Do they want it for a frozen section? Okay, don't guess how they want it sent. Okay, do not do this. So, do you want this sent frozen? No. Oh, well, do you want it sent permanent? No. Okay, don't guess what the surgeon wants. Ask what the surgeon wants. What is it? How do you want it sent? And lastly, can I pass it off? You do not want to pass the specimen off the field until you have gotten the surgeon's okie dokie. Okay? There is some documentation that is required for the specimen, and the circulating nurse is going to fill out a pathology slip. So we don't have to worry about that, but we do have to make sure that we label that specimen correctly. Okay? We want to make sure that we immediately identify them. Sometimes the surgeon will mark the specimen. Okay, that means they might put a stitch in a certain area of the specimen. You also want to communicate that information. Also, learn from me. If a surgeon takes out a biopsy and places it on the field, Do not pick it up. Do not move it unless you specifically ask that surgeon if you can, because they might have set it down in a specific orientation so that they can put a stitch in it. And the reason that they're going to do that is so that when it goes to the pathologist can orient the specimen as well. Here's an example. One surgeon that I used to work with, and she did a lot of breast biopsies, she would always stitch the specimen, or we would call this marking the margins of the specimen. And the surgeon would mark the margins in 2 places. She would put a long stitch on the lateral side and a short stitch on the superior side. Okay, so that would go on the path slip. And when the pathologist got it, he was able to orient, or she, the specimen in the correct manner. So if the surgeon sets the specimen down and it's a blob and you can't tell heads nor tails, do not move it until you get permission. Okay. You don't ever want to use water to preserve a specimen or keep it moist during surgery. That can distort the cells. Remember, we talked about hypotonic versus hypertonic solutions or isotonic solutions. Okay, we don't want to change or alter a specimen in any way. We don't want to cut it or staple it or grab it with a traumatic forceps or clamp or anything like that. Sometimes the surgeons will want to cut the specimen open, but that's for them to do, not us, okay? There are a couple different types of containers that you might see. Some are sterile and they can be opened right onto the field, like this container you see here. This top specimen is a gallbladder, by the way, with some nice stones in it. And then this is a sterile specimen cup down below it. So that can be opened onto our field. We can go ahead and put the specimen in there, put the lid on, and pass it off. Some specimens come preloaded with formalin, which the nurse will have, or there's also unsterile specimen containers if we have really large specimens. Okay. Different ways for specimens to be transported to pathology. Sometimes they have somebody from the lab that will come over periodically and pick up the specimens from the OR, so there's a special place that we put them. Sometimes personnel from the facility will just be responsible for taking specimens to the lab. Sometimes the nurse will run the specimen if there's information that we need right away. Okay, some different types of specimens. There are biopsies, like we talked about before. Frozen sections. So frozen section, you want to send dry or fresh. The pathologist is going to go ahead and freeze it and slice it. Take a look at the edges of that specimen and give us some feedback. As far as stones, we want to make sure that stones are only transported in a dry container and or sometimes alcohol, but never in formalin. Formalin will dissolve stones. Okay, so if we took out some kidney stones and we throw them in some formalin, the pathologist is going to think there's some sort of sick joke when they get the specimen container, because there's not going to be a specimen in there. So if you're not sure, just ask. Bulk tissue or organs or partial organs or very large specimens can be put in, there's larger containers, or they might have to be put in a leak-proof bag. If you did an above-the-knee amputation, let's say, there isn't a specimen container that's going to fit that lower limb. So sometimes we'll send cells or cultures, right? Washings or some fluid or some cultures, those kinds of things. We may have various collection devices or culture swabs that we're sending to pathology. Products of conception are also another type of specimen. Foreign body can also be another type of specimen. If it's a bullet or something like that, you want to make sure that you don't handle it with anything metal, because that will add to the unique markings on the bullet, and that's going to become a part of forensic investigation. They'll need to be able to look at that bullet for those markings. Some specimens that require special preparation, again, could be muscle biopsies, kidney biopsies, or frozen sections. During C-sections, we will oftentimes collect cord blood, and that may also have to go to the cord blood bank. And so there might be a special way that we have to prepare that as well. Radioactive specimens. Radioactive specimens could come from patients who have undergone surgery to implant radioactive seeds. They are using radioactive seeds for the prostate and sometimes for cervical cancer, I believe, as well. Special precautions have to be taken for handling these things, and the best thing to do is ask your facility for their procedures about that. And then lastly, autologous tissue for implantation. If the patient has donated his or her own tissue, then that could need to be preserved so that it could be implanted at a later date. So those tissues need to be handled according to your facility's protocols as well. And then they're also going to take into consideration the FDA rules and regulations as well. All right, wound closure. When it gets time to close the wound, when we pass that closing stitch, that's when we would want to initiate our closing count. All right. Whenever you pass a stitch loaded on a needle holder, you're also going to pass a forceps, and then you're going to anticipate needing to cut that suture. Those three things pretty much always go together. When the surgeon starts closing the wound, okay, you don't want to get your dressings up too early, because if the wound is still wide open and you get gauze sponges somehow up on your Mayo stand, the surgeon could mistake one of those for a Raytech, and those could go in the wound. All right. You do not want to ever put dressing sponges up on your Mayo stand before the skin is closed. Okay, and I don't even like them opened up onto my field until we are very near needing them. All right, but you want to anticipate the dressings. You don't want the surgeon to be standing there stomping his or her foot waiting for the dressings. Okay, so you want to anticipate those. So you're going to be, as they're closing the wound, they're going to use multiple stitches to close the layers. And so you're going to be still passing stitches, maybe changing forceps, sponging, cutting sutures, anticipating the drains, doing the count, or not the drains. Sorry, I was looking at this picture with the drains here, but of the wound dressings. And then when the surgeon is done closing, you're going to get a wet sponge and a dry sponge so that they can clean the wound. And then together you'll place the dressings. Okay. Once you've placed the dressings, then you're going to move your stuff back, and then you're going to keep that sterile. You'll help take the drapes off like we've been doing in our lab practices. All right, and then lastly, after the patient is out of the room, you're going to first make sure that you've contained all of your sharps and disposed of them properly. Then it's a matter of breaking down your back table, opening up all of your instruments, disassembling any instruments, getting those to decon. All right, and then coming back to help with the room turnover. In the meantime, your circulating nurse and anesthesia care provider are going to take the patient to recovery. All right, and then the circulating nurse will come back to help you finish the room turnover, and then you're going to get your next case. If there is a next case scheduled in your room, you'll grab your goodies, and the whole thing just starts over again in this wonderful, amazing, fascinating dance that we call surgery. So this concludes my lecture on case planning and intraoperative routines. I look forward to reading your money points and getting your thoughts on all of this information. Remember, preparation and anticipation are key. Look at the operating field, right? When you're wanting to anticipate your surgeon, keep your mouth closed and your ears open, right? When you're getting prepared, don't be afraid to ask questions. Work on developing a systematic approach. The more systematic you are, the more routine you are, the better you will function. Also, know the facility sharps protocol. If they use a neutral zone where you house your sharps and the surgeon picks up the sharp from there and returns it so that you don't have to pass it at all, then use that policy. It's very important to know what the facility's protocols are. However, in the lab, we are going to practice passing those sharps because I cannot, with a clear conscience, send you out there not knowing how to safely handle and pass sharps. Okay? All right, that is it. Thank you for listening.